So I thought it might be useful just to go through what investigate, because we seem to request a huge number of images and different types of radiology, interventional radiology. I just wondered if we could start going through maybe some of those common ones.
Yeah, so I think the most common is probably just a plain CT head.
Yeah.
But I think the key points are, for a plain CT head in all units, particularly in the UK, you don't have to put it past the radiology reg, because it's a decision with a neuro patient that's normally critical in terms of timing. You can order it directly, and as long as you ring the CT control room, they'll get it done in a good amount of time. Yeah. It is also useful, though, when you're requesting the scan, to help the radiologist then another pair of hands and eyes, and also opinion as to what could be going on with the patient. So if you include what the diagnosis is and then what reasons there are for the scan or what's happening clinically on the ground, it's another opinion there to help you and help the rest of the team, really. So it's both of those are vital points, I would say.
One of the things I've noticed a lot with neurosurgery is a lot of scans are done at other trusts. So it's really useful. I've found you get much more from the radiologist if you comment on whether there is another scan at another trust for them to compare to, because they often won't necessarily check other trusts' scans for comparison.
Yeah, so that's not available for the peripherals to access every other peripheral centre. But often when you've been able to download them from the other centres, then you can compare them, and we don't always have a set allocated patient hospital number in the tertiary neurosurgery centre versus the district. So letting them know that actually they can search it on just their name at a different centre is very helpful.
It's just mentioning that this patient's already had 2 CT scans in the last 2 days. Or whatever.
So CT heads, and particularly plain CT heads, they generally come with thick and thin slices, so the thicks are generally about 5mm versus something that's submillimetric. There's also bone and soft tissue algorithm images and image sets that are in one single CT head. Don't forget that the CT angle of the gantry is rotated, and that's to avoid the radiation to the orbits, to avoid cataracts. And so that gives you a slightly different perspective to MRI. But CT head's the most common investigation or initial investigation to look at anything that's going on inside of the head, and so it can give you an idea, a bit like in this image where you have some midline shift here and clearly blood of some acute and some chronic component to this right-sided subdural, and you can see the ventricles there and some left-sided hydrocephalus as a result. Also, it can give you an idea for blood and fluid, and in this case it's a subarachnoid hemorrhage with again very significant enlargement of the temporal horns of the lateral ventricles, and there's enlargement of the fourth as well, so all ventricles are enlarged, and this patient is likely to be needing either an EVD in the first instance, and then will be determined whether they need a shunt. The next thing that CT heads are good at looking at is air, and you can get this in post-craniotomies or in some chronic subdurals where air gets into the tubing, either the wound drain or the subdural drain, whichever your unit uses, and that can occasionally happen with confused patients who pull at the drain and occasionally will snap them, and this, in this case, you've got significant compression of the brain, and that could be an emergency on the ward where they need to put a cannula into the burr holes and again suck some of that air out, and air can give patients seizures, so they're at high risk of having that. The other thing that CT heads are good at looking overall at is edema of the brain, and in this case you can see some edematous reaction and some swelling of the right hemisphere, again with some midline shift. It can also pick up fractures, which can be quite difficult to pick up, and you'll get used to searching for those, particularly in the skull base. Determining a fracture between a suture can be quite difficult. And then infarction, don't forget that infarction is shown on CTs, but again only in a delayed fashion of at least 6 to 14 hours. Occasionally it will be earlier than that.
So then there's the next most common thing that we probably order, which is a CT post-contrast, would you say?
Or CTA is probably the next most
CTA.
common, but I think CT post-contrast, everyone knows, is quite good for looking at abscesses, or if there's any contraindications for an MRI, or often it's not sure whether something's MR conditional or not, then CT post-contrast is a good interim measure to try and rule in or out some neurosurgical emergencies.
But a CT angiogram, it's quite important to differentiate this from a DSA, because even though they are obviously often used to assess the same thing.
Yes.
A CT angio is done by radiology in the radiology department.
By a radiographer.
Yeah,
in the CT scanner.
In the CT scanner.
Effectively, you get a green cannula in the ACF to get a good flow rate on the injection of contrast, and then they time it on some CT cuts, and then they'll start scanning with the contrast in the arterial system. Occasionally it can be late and then or early, and they'll catch a venous phase, or it won't be fully in the vessels. But a post-contrast where they just inject it and it doesn't matter, you can go a couple, even within the next hour, and it will still be there.
But that's much different to a DSA, which obviously...
So a DSA is more, has got more risks. They're going through the groin, so you can get groin hematomas, retroperitoneal hematomas. You've got risks of strokes.
And it's done by interventional radiology.
So it's done by a radiology consultant with a neurovascular interest. So and you can't. You at the moment can't get that 24 hours a day, 7 days a week, 365 days a year.
And the main reason you do those scans.
So CTA is very good at determining, and to be fair, they've got much better because at the base of the skull, that's where most of your vessels are. You still get artifacts from the skull base, and so you're for very small aneurysms, you might not always pick up those very small aneurysms. So effectively, a DSA is the gold standard. A CTA will pick up probably 98+% of them, and to be fair, with the technology improving, it's probably getting close to 100%, but it's occasionally we'll be surprised and find something.
Right, and that's done to assess if a patient's got an aneurysm. But it can also be used for any other neurovascular, well, not all of them, but most neurovascular conditions like fistulas or AVMs. And it also helps. It's a little bit different from a CTA because you can see the flow of the fluid travelling through the whole malformation, whereas on a CTA it's just a plain cut at a snapshot in time. I remember when I first started here, people asked me to get a CT scan that's Brainlab compatible, or I think it's called a guided CT. I didn't ever know what that was. I just put it in the request, but I've later found out what it is. Why do you get that?
So that's for helping with a software either called Brainlab or Stealth, depending on which type of software that people use. But in theatre, if you want to get sub-millimetre accuracy and you want to make the perfect opening and make it as small as possible, and try and reduce the wound size, and you're getting into exactly where you want to inside the head, because the head is clearly very spherical. Sometimes it can be a little bit tricky. You can, on craniometric points, on pure measurements, just be slightly off. and for some operations it's quite critical that you're spot on.
Right.
And to be fair, you want to make an operation as good as you can. So often Brainlab scans, the difference with them, or stealth scans or navigator scans or CTs, they include the face. That they'll irradiate the eyes, which they commonly try to avoid in plain CT heads because you'll get cataracts. And occasionally they'll do fiducial assisted, where they put some up to 9, generally at least bare minimum of 6, depending on the software, but little markers that stick on that they scan with and stay with until they go down into theatre. And they scan them with those markers on as well.
Okay.
That are sticky, that stick onto the skin, so you need to shave the head where you put them on and mark around them.
So the only other CT head I can think of is a fine cut CT.
Yeah, so occasionally that's used to very carefully look at the skull base, if there's CSF leaks, or if you're trying to navigate. So, for example, for pituitary, and you can get varying anatomy of some of the air cells. You don't want to be misnavigated into any of the orbital spaces.
Okay. And something that I've never ordered is a stereotactic CT.
So again, the angle of the gantry of the scan is slightly different. Right. They'll probably do a slightly different cut, and also they'll have the frame placed on them before. Often whilst they're asleep in theatre, they'll go to be wheeled in a trolley with the frame, and then that frame will get attached onto the scanner bed, and the whole scan will be done in reference to that frame.
Right.
So they're slightly different, but yeah.
Okay.
Yeah.
And then I guess the other scan that we do a lot here is MRI.
Yes.
You do it with or without contrast?
You can do, yeah. Depending on what you're looking for, yeah. And we do a lot of that here. Both cranial and lumbar.
Yeah.
And then often if you're trying to do lumbar, and the most common one is for cord equina, they'll often scan a little bit of the rest of the spine on a standard T2 image just to have a look and make sure there's no compression of the cord anywhere else.
I guess when ordering those scans, the key things to remember is just that you need to do a safety checklist with the patient to make sure they're compatible to go into an MRI scan.
And they're not pregnant. They don't have any metallic implants, particularly hearing aids or even dentures. And
if you do get stuck with a particular implant, because a lot of the neurosurgical patients have got implants, you can just check with one of the senior surgeons, because they're MRI safe.
These days, although if the patient's either heavily sedated and you can't find out, and you don't know if they even have got any implants at all, the other way of doing that is then doing x-rays to find out, and occasionally we have to resort to that if we can't find. Yeah,
so a series of x-rays. I think it includes the skull,
and often the chest, And then depends how far you're doing your spine and on the MR scanner, so that's a little bit unique to each unit.
More specialist scans that we've ordered, Milograms.
So where you inject contrast, again the same type of contrast, iodine based, into the CSF, and that's mainly used in patients that can't have MRI scans, either because they've got often spinal cord stimulators, although they're now becoming more MRI conditional. But occasionally you'll find old patients with pacemakers that are non-compatible. They go for a Milogram, and then you just basically see where the compression of the cord is, or of the nerve roots, depending on the level.
Excellent. I think that's pretty much every.
That's all the scans that you'll commonly come across. Occasionally you'll get some odd spec PET, radionuclear, basically nuclear physics scans.
Right. Okay, so the shunt series, I guess that's that's something that we order a lot.
You order a lot of, and on your first day you don't have a clue what that means. But effectively it's just a set of x-rays following the shunt and where it goes. So the most common one is a VP shunt, but you will get other varieties of that. The main things there are to determine whether the tubing's intact, if there's a fracture, at the placement of where it is. Occasionally it will move and instead of being in the peritoneum then go into the extraperitoneal space. And also it's used to sometimes confirm what the shunt valve setting is. So particularly the skull ones, there's often some valves on there. You can, from the X-ray, tell what the setting is and what the pressure release.
I think one of the key things is with the shunt series basically consists of the head, a
head, neck,
chest,
and abdomen.
And the abdomen has got to be AP and lateral because otherwise you can't tell.
Absolutely, yeah. Occasionally for necks you might need AP and lateral for that, but yeah, abdomen you need to be 100% sure that it's definitely inside the peritoneal space rather than sometimes it can go out of.
So I think my standard request would be full shunt series, head perpendicular to valve.
Ideally, because then you can read the setting. If it isn't perpendicular, then you can't really read it, and then you have to go for another. And
then AP lateral neck, chest, AP lateral abdomen. And you don't necessarily have to do all of those if they've recently had one with that shunt in place. So
but occasionally you'll come across some that there isn't an overlapping X-ray, and therefore a fracture can occasionally get missed. So that's another key thing to.
Would you ever get a CT scan to assess a shunt position?
You can do, yeah. Sometimes it can be pretty difficult with if the abdominal end is very superficial, and it can still be intraperitoneal, but you can't be 100% sure on the X-ray. Or you can have a pseudocyst around the tip of the shunt tip in the abdomen, and therefore it's not fully draining, and only really a CT or sometimes an ultrasound, depending on its location, will tell you. So the other one is LP shunt, so a lumbar peritoneal. They're less commonly used. They're a little bit more difficult to maintain, and probably have some more complications from a tweaking of the valve setting. I think ventricular catheters are probably easier, but you've got a risk of a stroke clearly with a ventricular catheter. So some people like to avoid that.
Right, I see.
But the lumbar peritoneal shunts, again, similar beast, but you just have to do AP and lateral, and often the valves are not adjustable.
No.
Often.
So
but it can be, but often not.
But it's just an AP and lateral of the ankle.
Yeah.
Okay.